Welcome to Unleashed, the show that explores how to thrive as an independent professional. Unleashed is produced by Umbrex, which connects you with the world's top independent management consultants. And I'm your host, Will Bachman. I'm so excited to be here today with our guest, Jason Bernd, who is the president and COO of Novant Health Orthopedic Hospital in Charlotte, North Carolina. It's one of the hospitals that's part of the Novant Health Integrated Network. Jason, welcome to the show.
Thanks, Will. It's good to chat with you today.
So, Jason, would love to hear about the past, month, 6 weeks, what it's been like running a hospital in the midst of the coronavirus.
Absolutely. I can say, Will, that it's been an incredibly long journey, but one that I'm very proud of just to see how the frontline workers come every day to take care of patients, to watch the collaboration that happens. And interestingly, what I'll say is that the teamwork has been fantastic. The community support has been fantastic. So we've really seen a lot of the best of what people bring together. I think what I would characterize as the biggest thing with taking care of coronavirus is that our assumptions and our understanding of the disease and how it progressed in the community changed sometimes every 30, 40 minutes. And so the need for the team to communicate, the need for the team to be flexible was paramount in order to make sure that we prepared and that we had everything ready to keep our team members safe, to keep our community safe, and to help take care of these patients. So it's been a really, I think, a successful journey for our organization, taking care of our community, and one that I think brought out a lot of the best in what we see people do.
Give me a little narrative. Let's walk back to earlier in March when we all started realizing how this was getting starting to get serious, or maybe it was even earlier in your case. How did you organize as a top team there at the hospital and part of the broader system in terms of making sure you had the right ventilators and other PPE and supplies? Maybe there was some work around just how you're going to organize the shifts, or how do you isolate coronavirus patients. There's probably a whole multiple streams. Like, how did you organize and set up different work streams to do the planning around this? Would love to hear that narrative of how you started, and then we kind of walk through how it played out.
Absolutely. So the way we're organized as a company, we have 14 hospitals across North and South Carolina, and we have significant corporate support, whether that's supply chain team, whether that's infection prevention team. And so the way that we organized was there was really kind of a corporate structure that would try to make sure that we made consistent, centralized decisions around disseminating information, particularly around infection prevention, around supplies, et cetera. And then that group really helped guide the best information, the best science, to make sure that we were consistent in how we treated visitors and which personal protective equipment that we wore. I think that was handled really at a system level. And then from a communication perspective, we very quickly stood up daily phone calls that were also kind of operational level and a local market perspective. So each facility had daily phone calls, and then we kind of had, for example, a Charlotte market call. And I think that communication was really important to make sure, because the information changed so rapidly. You could have a conversation at 9 a.m. and by 11 a.m., the governor had made an announcement and things had completely changed. And then by 1 p.m., you had a change from the federal level that you had to react to and implement. And then by 1:30, you had the CDC making a recommendation on masking that was different. So I think what worked really well was that we really quickly moved to centralized decision making and to having a command center open at a local level as well as a system level that could handle real-time questions and that could really prep communication that went out. I think something we learned as we went through was that there needed to be communication about the plan and then communication about when we're going to execute the plan. And so I'd say that was another big learning, is that because things change so rapidly, in order to get people comfortable, in order to get team members comfortable, if we talked about a plan, we also had to commit to waiting to all implement at the same time, so that there was not confusion or inconsistency in how individual facilities implemented infection prevention measures as an example. So again, just the structure and the communication, I think, was really important part of the leadership to help our preparations be successful.
Talk to me a little bit about operations. So I think that you may have shut down certain types of elective procedures. And did you, kind of say all coronavirus patients will go in this wing of the hospital? Or talk to me about some of the things where you had to quickly shift from normal operating procedures.
Well, I think that's a really interesting question operationally about what we did differently. And I'll say one of the things that we made a decision as an organization was we decided to cohort patients that had COVID to basically one facility per city. As an example, we had our main campus in Winston-Salem. We really cohorted the patients and we decided to transfer them from outlying facilities to the main tertiary hospital. We did the same thing in Charlotte. And I think in the long term, we saw significant benefit from that. One was because the expertise that was developed for those team members as they became much more comfortable taking care of patients that had COVID. We were able to really disseminate best practices from physician care, from nursing care, as that team developed expertise. And in addition, we were able to really do some things with the patient rooms. So we installed HEPA filters that would actually extract the air and create a negative pressure environment in the patient rooms. And all that really is just a fancy way to say that we basically, sucked all the air out. We exchanged the air out of the room constantly just to make sure it was safer, that there wasn't any airborne challenges. And what that gave us was an ability to have a safer environment if we had to give breathing treatments to patients or had to intubate patients and things like that. And so we did choose to cohort patients. And so I'd say that was a big operational decision we did that I think really did pay off in the long run. I'd say big picture, the other thing it did allow us to do was, so for example, I run a surgical hospital that's connected to our main campus. And we chose to basically keep the patients with COVID away from my facility, and that will allow us to open my facility a little bit earlier, just because we'd never had exposure to COVID patients in this building. We did have them in the main campus. I think that the other thing that we really, really worked around was supply conservation. I think you saw some significant efforts around the organization about, do we use cloth masks? Do we have universal masking? Do you have cleaning of masks? And I think as an organization, we did a pretty great job evaluating best science and really putting ourselves in a situation where we felt like we had ample supplies to help keep our team members safe and our patients safe. And I was really proud of the way we coordinated that and worked with that across the health system. So those are just a couple of examples of how we organized.
Yeah, talk to me a little bit about the masks. I mean, that's been so much in the news. And what are some of the things that you did? You mentioned cleaning of masks. Is that possible to somehow, take a mask that's been used and, I don't know, irradiate it or
Yeah.
do something to it to kind of so it's safe to use again?
So I think here's the interesting thing. One of the other things that we found about communicating during a crisis like this is that sometimes we actually decided to implement things that were actually not necessarily the best practice from a science perspective, but they were really important for team members to feel safe and secure. So as an example, we as an organization went to universal masking for all team members pretty early into this. And the science would say that you really only need to mask patients who are sick, and that you really don't need everybody to wear masks. However, people were really uncomfortable. There's a lot of unknowns. There's a lot of team members that were asking if they could mask. And so we decided as an organization to say, you know what, let's have everybody go ahead and wear surgical masks when they're within 6 feet of a patient. And that way it gave people a sense of security. It gave a sense of consistency. So there was no confusion for our clinical team members about, can I wear a mask? Can I not wear a mask? And so sometimes we found that with communicating, we have 25,000 employees, communicating with that many individuals, sometimes we had to make decisions that helped promote a feeling of safety, even if it wasn't necessarily completely necessary from a science perspective. So we did go universal masking. We used the easier to find surgical mask for that. And then we had very clear definitions of when did you need to use the I guess the higher level mask like N95 masks. And for us, that was identified as really with the CDC with aerosolizing procedures, where you were working with the patient and you could potentially have the COVID disease aerosolized out into the environment. So I think with universal masking, it made some consistency for our team. And then what we have been doing, we had two processes to basically clean and reprocess masks. So one, what we started with is we do have these UV light disinfectants. And there are several health systems. There's one out of Nebraska that had basically used their UV light cleaners, which we will routinely use to clean up after patients that have C. diff infections, or we might use them to clean up ORs, just to keep ORs particularly clean. And you can use UV lights to disinfect masks and reuse them. And so we had that process going for a while. And then what we are doing now is there have been several other organizations that have looked at using the hydrogen peroxide as a cleaner that really does help disinfect the masks. Our organization, because the infection rates have not been as high as in some of the harder hit areas, we've actually been cleaning these masks, but we have not put them back into circulation yet because we have not had a shortage. So we have been able to continue to use new masks for all of our clinical team members. But as an abundance of caution to make sure that we're prepared for any potential surge, we have started reprocessing N95 masks, which have been very hard to find.
You mentioned sort of these regular calls in the local market there in Charlotte. Were those with including with sort of hospitals that were outside of your company's network, so that you were coordinating as a whole city? And what were those calls like? What was the agenda? What was discovered? What would we have heard if we had listened in on one of those calls?
Yeah, absolutely. So most municipalities have some form of emergency operations, and so Charlotte, Mecklenburg County have an emergency operations center, and that group, we stand up that group when there's severe weather. We stand up that group when there's the RNC or the DNC. So the Mecklenburg County Emergency Operations Center opened up fairly early, in the middle of March. And what they have is police, fire, EMS, hospitals. They have the NGOs, not-for-profits in the area, Health and Human Services. And that group really helped operationalize the county's response and the local government's response in coordination with state and, folks from the governor's office. So that group did have, they had a command center that was open. I can't remember if it was open 24 hours, but it certainly has been open during daytime hours, 7 days a week. And so the hospitals used to have a representative there, again, some of the other organizations around town. And that group really helped with the countywide decision-making. That group was responsible for Mecklenburg County and Charlotte actually initiated a stay-at-home order before the statewide order was issued by the governor. So that was the group that looked at the facility, hospital censuses, hospital capacity, looked at the community infection rates, and they made some of the calls around some of the public health services. So significant coordination. That group was also responsible for planning to see if we needed to build field hospital, if we needed to have excess capacity besides the regular hospitals. And that group does continue to evaluate at what point do we start to lift some of the stay-at-home orders, some of the restrictions that have been in place to try to keep the community spread low.
Let's talk about staffing a little bit. So was there a need, or did you have to redeploy some medical professionals to work on the coronavirus, maybe outside their specialty?
Yeah, so one of the interesting things that happened was that, like most health systems, we stopped elective patient surgeries, elective procedures. And what that just means is that we moved to a situation where we really only took care of time-sensitive patient needs. And that was done to free up resources to make them available to handle any patient surges. And so patients that had, medical emergencies, that had urgent cases, patients that had disease processes that were advancing were still taken care of. But we did see probably about somewhere between 50 and 60% of our patient care services really stop. And that allowed a significant amount of team members to be redeployed as needed to other services. What you found is imaging services like radiology and surgical services were areas that were particularly hard hit with loss of their regular scheduled work. But we used those team members to do things like we set up screening at all of our entrances for team members, for guests, for patients. And so we deployed clinical team members to do screening. We beefed up some of our nursing supervisor services and redeployed team members there. We redeployed team members to our supply chain department to help with the purchasing, supply chain routing. So we had a pretty significant, pretty massive redeployment plan and scheme that not only addressed whatever day-to-day needs there were, but also planned in case there continued to be a surge of patients. An interesting thing, Will, that happened, and I know a lot of businesses experience this, is that so for health systems our patient volumes never went beyond our capacity in Charlotte. So we always had more capacity than we had patients. So we actually ended up in an interesting situation where we really had to work hard to try to find hours for our clinical team members. So if you could imagine that you're a nurse, you're a caregiver, you're primary breadwinner for your family, and you are preparing to potentially go to an area where you typically don't serve to take care of COVID patients. But in the meantime, you might be not getting your regular scheduled hours. So as an organization, we had to really think about how do we, care for our team members? How do we make sure that they can take care of their families? And we actually, our organization created a $10 million emergency relief fund that our team members could access so that in case they had challenges meeting their financial responsibilities, they're able to do so and have some peace of mind while they potentially had their regularly scheduled jobs disrupted. So there was an interesting balance that you could see across the country, where in some places they certainly had facilities that were overwhelmed, where people were working significant hours, where they were redeploying to places where they had not necessarily worked. In other areas, you had people waiting for a surge that never exceeded their capacity. So you also struggle with really keeping these frontline health workers employed, keeping their paychecks running, keeping their benefits, and making sure that they're okay so that they can focus on taking care of the community when the community needs their help.
Yeah, that's a story that I don't think I've seen as much of. Is that a lot of people are recognizing the healthcare workers as heroes, and in some cases, if they're not directly involved in coronavirus care, maybe they're actually their income is suffering.
Right.
How has it impacted the finances of hospitals? I've heard that, some of the elective surgery might be some of the more, profitable type of procedures to do. And if a lot of those have gone away, how is this impacting hospitals with the kind of decline in some of those procedures you talked about?
Yeah, it's a significant disruption to our organization. We are a 501c3 not-for-profit. So we are, a not-for-profit entity. However, we do have nearly $5 billion of revenue. So we are a large organization with a significant amount of patient care revenue. And so I'll give you an example. My hospital, which does take care of, it's primarily orthopedic and spine services. So most of that business is what you'd consider elective, where there is a choice as to when patients have their surgeries. And our revenue in April was down 75% from traditional revenue. So there's a significant impact to revenue, to hours that team members get. And so we've had to really work hard to make sure that we do what we can to take care of our team members. And then we as an organization do have the benefit of our size. We did line up financing just to make sure that we had working capital to make it through this place. But we're proud that we have not had any furloughs. We have not had any displacements at this point with our health system. And I think that we came into this epidemic with or pandemic with a strong, financial health. And so I think we'll emerge from this still strong, but it has had a significant impact on our business operations. And even with some of the money that's come from the stimulus packages, that is not, that's not going to cover the cost of these events, of the things we stood up. I mean, if I just think about the supplies and equipment we've had to purchase, again, we typically have 22 medical ICU beds in our main campus, and we were in a situation where we were going to be able to deploy 200 ICU beds. And so, as you can imagine, the amount of equipment and supplies necessary to stand that up is pretty significant. So, a large investment that the health systems have made to make sure their communities are safe, significant hit to the way that their economics work since the canceling of a lot of imaging and surgical services. And so this will be a long road to sort of recover from the effects of really pausing everything to make sure we're ready to take care of coronavirus.
You talked earlier about how important it was to communicate and communicate maybe simple messages because you're trying to change people's behaviors. Talk to me a bit about, as the leader of the hospital, what have you done to be out there and to be visible, to be talking to people one-on-one or in small groups to make sure you're kind of understand what's going on at the front lines? What have you done in terms of that, of either management by walking around, touring, and being out there and present?
Absolutely. So I'd say one thing is that being very intentional about making sure that I, as well as other leaders, are getting up to the floors to speak with the frontline team members, to round on them, to thank them, to celebrate what they're doing. And so, I would put my surgical mask on and I'd get up there and I'd round and I'd help make sure that team member feels like this is a safe place. I'm going to be up here. I'm going to be walking through with you. The other thing that we did is for our kind of supervisors and above was we would just have a daily 15 to 20 minute check-in each day just to debrief what's happening, to ask questions, see what questions their frontline team has. I think that really helped my team in particular feel connected, to feel like they were getting the latest information that they could. So just really quick, huddles. It was challenging because this all had to be in Zoom. We really took the social distancing seriously as well. And so almost all of our meetings have been in Zoom, which is a tougher way to huddle. But then in addition, making sure every day that as an administrative leader, I'm masking and I'm getting up and I'm seeing the team members and I'm communicating with them and talking with them. Another thing that we did that I think was really impactful was that we put whiteboards up at the front entrances to really celebrate the successes of taking care of our patients. And so as an example, I think as of this morning, I think that we had about 200 patients that have recovered and gone home from just our facility. And we had about 35 patients that were in an ICU, that were on a vent, that have recovered and have come off that vent and gone home. So each day we update those numbers just to make sure that people know the impact that they're making every day, that they're seeing the progress, seeing that we're winning, that we're having great success treating patients. And I think that type of thing really helped encourage the team as they see things changing a lot, to remember that we're having a lot of people recover and go home.
We talked some about how you've been connected to the local Charlotte market. How have you been connecting with other hospital administrators? How have your clinical folks been connecting with other clinical folks across the country to sort of be sharing lessons learned as we go through this?
One of the things that I think makes me most proud is just, healthcare is in the business of taking care of people. And so the information sharing is pretty fantastic. And particularly you see that around physicians. And, our ICU doctors in Charlotte, North Carolina are communicating with physicians in Germany and physicians in Italy and physicians around the world, sharing best practices, learning, sharing ideas. And so we've seen significant amount of information sharing, collaboration across the medical community, particularly physicians. There are a lot of means of connecting with other health systems around the country. So the North Carolina Hospital Association organizes a weekly phone call. The American Hospital Association organizes phone calls as well. So there's been a lot of great connection points to try to share information. In addition, I think that the states have really tried to help with some of the data transparency. So you can see reports, whether it's New York City or whether it's the state of Massachusetts, whether it's the state of North Carolina, and you really have seen a desire to try to publish a lot of information so that people can see what's going on and feel informed about hospitalizations, about recovery, about mortality. I think that type of information really helps to build trust. It also helps us plan resources and make sure that we're allocating resources where they're needed in case there are areas that do need some support. So a lot of communication, a lot of individuals spending a lot of time making sure that we're trying to redeploy to support the areas that have the greatest need, whether that's in our local communities or our state or whether that's across the country.
I'd love to hear about what your lessons learned have been as you've gone through this, and you've shared already some of the things that you've been doing that work, like the whiteboard out front and your daily rounds and so forth. Any lessons learned that you've picked up that would help you maybe do something different next time?
Yeah, I'd say one of the things that was most impactful for me is my boss, Saad Etisham, who's the president of our market. He very clearly in the beginning said to folks, I want you all to recognize that this is an event and this is going to have a beginning and it's going to have a middle and it's going to have an end. And so from the beginning of the coronavirus pandemic, he very clearly helped us recognize we're going to get through this, and this event is going to pass. So I think as a leader, just helping people feel the confidence, just that they're solid ground, that we're going to work on this, we're going to work really hard, but we're also going to start to think about recovery. So I'd say that was motivating, inspirational, just to kind of hear that and remember that from the beginning. I think that the other thing is recognizing that the emotional needs of your team are just as important as facts and figures and numbers. And so we've had a lot of organic things happen. We've had teams that decide to do a spiritual prayer huddle before their shifts. We have team members that share kind of messages of hope. We have a lot of team members supporting and thanking each other. And really impactful has been the community. I do think that our frontline healthcare workers have probably been fed almost every meal for the last month. Lunch, we have a different community organization that's donating meals, that's donating snacks. And so there has been just a real degree of support and a real feeling of the communities behind us. And that really means a lot to the team that's coming in every day. I think the other thing is recognizing the need to coordinate. So I talked a little bit about this, but planning and execution, and to do that synchronized so that you can say to people, right now we're talking about a plan and we will tell you when to execute. I think that type of language really helps in a dynamic changing environment, because it helps you avoid people jumping out and making changes early. Because when one facility is doing something and another facility is not, it just creates a lot of uncertainty, and people feel unsettled when things are not consistent. So I think that those were certainly really important. And I think, again, as a leader, helping people also take time away. So we did create kind of an Alpha Bravo team with our leadership team. You see a lot of physicians that did this. And we really made sure that we kind of checked on each other, checked in with folks, and tried to make sure that people could get some time away to recharge their batteries, because there was, significant amount of hours, significant amount of work. People, there's a significant amount of stress you're carrying in the background that you may not even realize. So I think as leaders, really focusing on it, could have sort of forcing each other to take a day off here and there to kind of get away, to recover and come back recharged, I think was a really important leadership lesson as well.
Talk to me some about how you have been working to plan for kind of a gradual, safe reopening so you can start doing those elective surgeries again and start doing those other kinds of procedures. How are you
Yeah.
planning around that?
So I'd say that we actually have, I think from the day that we stopped elective surgeries, we've actually been planning for what the restart looks like. So I think another lesson is, again, this is in these event-based situations, having the planning for recovery ongoing, so that those wheels are in motion, so that people's mindset is ready for that. So I'd say that we have been planning restart all along, and we actually will, as an organization, restart next week with our kind of elective surgery starting up again. We'll be selective. We'll be testing all those patients as they come in. We'll be making sure that we take care of patients that we expect will need sort of less hospital services, just so we don't overwhelm some of our critical care areas. So we'll be pragmatic about it. We'll be safe. But I think that planning has already started, and it does take a significant amount of effort to ramp things back up again. And again, there's a real need to communicate. There's a real need to be consistent, so that people feel safe, and and that people are, yeah, it's a little strong, like that people are sort of following best practice guidelines. For example, there is a tendency to want to wear the safest protective equipment for all patients. But if we're going to be testing patients for COVID and ruling out that they do not have COVID, then we need to remember that we can use our normal sterile precautions for those patients. So really trying to help lead people through to recognize that there is going to be a day where we're all not going to be masking. There is going to be a day where we're all not going to be wearing a 95 mask where we're taking care of these patients. And so how do we start to use the what we know, use testing to make sure that people start to reestablish those behaviors of using standard precautions for patients that we know do not have COVID. And I think that helps demystify the COVID a little bit, because there certainly is a level of reaction of wanting to be as safe as possible. And sometimes that is a little bit overkill, and sometimes that actually can potentially cause other challenges and delays if you're using the highest level of precaution where you really don't need it.
Yeah. And what is the status of testing now? Are you able to do a test and get an answer, in a short amount of time?
We do. We have several platforms that are doing rapid test turnarounds, and so there are several different vendors that are providing that. Several hospitals have in-house molecular labs, so they have been able to do in-house testing all along. We started with an outside reference lab company that did our testing, and as technology and innovation has come, we've been able to put in-house testing in our facilities, so we can get testing turnaround in 30 minutes for patients that are in the hospital. And then what we do is just sort of plan around, what criteria to use for rapid testing versus a 24-hour testing turnaround. And then we just make sure that we're using those tests in the appropriate manner in the appropriate place. And, each test has a different, specificity and false positives, false negatives. And so you just really look at that to make sure you're using the best information to make the best decisions for patient care. But I'd say that early on, testing was a significant challenge. So just to give you an example, at our peak, we would have just as many patients who are awaiting tests as we would have patients who are positive. So you had a pretty significant burden in the hospitals where you didn't know if they had COVID or not. But I was very proud of, testing organizations around the country that we pretty rapidly saw testing times drop. We saw the real-time testing come online. And so we're at a point now where really we can roll out COVID for any patient that comes, to the hospital within 30 minutes. It makes a big difference in us conserving personal protective equipment and making the right clinical decisions on where to put these patients and how to take care of them. So the testing is significantly better. I do think we are working with the county and the state to understand what does it look like to have rapid testing, antibody testing available for the broader public. just so that we can do some tracing and isolation if we do loosen things up in the state. And I think that type of thing would be a best practice to try to come off of some of the more severe stay-at-home restrictions that have been in place.
So you'd be able to, to kind of test the patient, and if you need to, do a procedure that day, you can do it within half an hour. And I guess they stay isolated in a room or something for half an hour with a mask on. And then if they don't have COVID, you can bring them into the hospital, and they don't necessarily need to wear a mask. And what about
Right.
what about sort of, I suppose that would be anybody who's going in. So if they want to bring a visitor or something wants to go in the hospital, you're maybe putting a much tighter
So
controls around that as well.
So we, for several weeks, have used basically paper-based screening for guests. Well, so sorry to back up. We have visitor restrictions. So basically, we've restricted visitors. So really, for the safety of patients, for guests, for team members, we really are at a situation where it's mostly end-of-life situations where guests are allowed to come in. For the most part, we're really restricting folks to have no visitors and encouraging them to not come in. And a lot of patients, even if they come in for a surgery, their family members are waiting in the car because they just feel more comfortable doing that. They certainly are welcome into the hospital. We have safe space for them. But as you can imagine, there's just been a lot of desire for people just to have social distancing in place. So we do have visitor restrictions across all the hospitals, across all the health systems in Charlotte, that I just think helps reduce the volume of traffic in the hospitals, which I think has been really helpful. And then when patients come in, when guests come in, when team members come in, we are checking temperatures. We are asking them questions, screening them to see if they have potential symptoms. And, we are asking them to, wear a mask if they're coming into our facility, just for the safety of our guests and our teams.
Fantastic. Well, Jason, this has been incredibly informative, and I'd also say very hopeful to hear about all the amazing things that your facility has done and how you've been working to protect both patients as well as your staff and team members. I'll include a link to the hospital in the show notes for people that want to kind of follow up. And thanks so much for being on the show.
Thank you, Will. Appreciate the time and the opportunity to catch up.